subtotal palmar fasciotomy for the Dupuytrens contracture. Definition of the procedure is a surgery indicated for patients with advanced contracture of one or more digits. The procedure is designed to remove only the pathologic fascia responsible for joint contracture. And this picture is kind of just showing what it does. It bends the two fingers, thickening of the skin in the palm. Purpose of the procedure is to restore restricted movement and impaired function of the right hand, fix contraction of the palmar fascia. Expected outcome is remove nodule in the right palm and repair Dupuytren's contracture. Our patient is John Elway. He's 59 years old and he is a male. Signs and symptoms: pain and tenderness, visible pitting and dimpling on the right palm, visible deformity of the fourth and fifth digits. Allergies: he has no known medical allergies. He takes a men's multivitamin. Patient history is good physical health, 2 previous arm fractures over 10 years ago. Last oral intake is a ribeye steak, steamed veggies, roasted potatoes, a Bud Light, and he has been NPO for the last 8 hours. HP and other relevant information: 59-year-old male suffers from Dupuytren's contracture. The patient has noticed thickening of the skin over the years, which later turned into pitting and dimpling. Pain and tenderness was soon to follow, making it hard to perform simple tasks. Patient noticed that his fourth and fifth digits on his right palm started to curl, making it painful to straighten. Patient is in good physical health with no known medical allergies, taking no medications other than his multivitamin, and he has no known medical conditions. Preoperative diagnosis is a stage C Dupuytren's contracture. As you can see, he already had his 2 fingers are starting to curl and making it difficult to do simple tasks, and that's why he is getting surgery. How diagnosis was determined: history and physical examination, as well as by direct examination. A standard x-ray was done. What happened? Okay. So this is just some of the anatomy. Oh my goodness. The hand is made up of 3 regions. We got the wrist, the palm, and the fingers. And as you can see, we're going to be dealing with the bones, the phalanges, and maybe some of the metacarpals. Oh my goodness. Sorry, guys. Simple anatomy, the bone anatomy, which I'm sure I'm not the only one who went over that. But like I said, we're going to be dealing with the fourth and fifth fingers. And this is just showing some muscles and tendons in the hands. And I wanted to show you guys the nerves that run through the hands. We'll be mostly dealing with the ulnar nerve, and then the arteries. And then this is a picture showing exactly what's going on with the Dupuytren's contracture. He does have the nodule, which is going to be removed, and this is the cord. So the cord will be cut and the nodule will be taken out. And he also has showed the pitting and all that. These are possible incisions, and this is the one that they use for the more complex surgeries, but he's going to be using the more simple one right here. And then let's see what else is on here. This is another picture showing exactly what's going on with the contracture, the thickening and tightening of the fascia, and how it's pulling those fingers down. And then this one is showing the nodules under the skin. It's thickening, forming cords of tissue that pull the involved fingers inwards toward the palm, which is one of his main symptoms, and that's why he is having surgery. General and procedural specific equipment: the dermatome have available hand table attachment to the OR table, a lead hand tourniquet, and insufflator. Specific instruments: plastic instrument tray, minor orthopedic instrument tray available. 2 instruments. The Stevens tenotomy scissors curved, used to perform delicate surgery. The small and sharp blades allow for precision cutting of the sensitive skin and delicate tissues. We also have the dermatome, used to cut thin slices of skin, called a split thickness skin graft for grafting. Specific supplies: the impervious stockinette, the S-March band, marking pen, number 15 knife blades, 3 of those, ESU pencil with needle tip, fluff gauze, and elastic bandage. Suture and tissue usage: left open to heal gradually, so we're not really dealing with sutures, but we want to also add the non-adherent dressing, the skin grafts, and the splint. Pharmaceuticals: 50 milliliters of 0.5% lidocaine without epi and antibiotic solution. Operative preparation is test power equipment prior to the patient entering the OR. Surgery team must remember the patient is sedated but conscious. Keep conversations and noise to a minimum. Anesthesia is a bare block, which is preferred, but you can use general. Patient positions and supplies: we're going to do the supine position with affected arm positioned on attached arm board, safety straps, headrest, padded arm boards, and pillows. Skin prep, beginning at incision site on the palm and moving outward to include fingertips up to axillary region. Draping: 3/4 sheet laid over arm board table, impervious stockinette placed over arm, and unrolled up to axillary region with an extremity drape. Practical considerations: have x-rays in the OR. If a skin graft is anticipated to be taken, the surgical tech should confirm the donor site with the surgeon. And then procedural steps: the surgeon may or may not use the lead hand to keep the hand in place. If not used, the surgical tech will be responsible for holding the hand and digits in place. The surgeon marks the incisions with the marking pen. If a free skin graft will be used, it is first taken. Procedural considerations: the graft is often taken from the medial region of the arm. The surgical tech must keep the graft moist by wrapping saline soaked sponges around it until healed. Using the number 15 knife blade, the surgeon will make 1 or more incisions on the volar or palmar surface of the hand according to the extent of the disease. For extensive contractures, a Z-plasty incision may be used so that the existing tissue can be used to cover the palm. Procedural considerations are: the surgeon must use several number 15 knife blades. Make sure to frequently change the blades to avoid the surgeon using a dull blade. Number 5, the incision is carried down to the palmar fascia, taking care to avoid injury to digital nerves and tendons. Using Adson tissue forceps and curved tenotomy scissors, the surgeon dissects the contracted fascia away from the underlying nerves, blood vessels, and tendons. Procedural consideration: this dissection can be very tedious and time-consuming. If the contracture is advanced, the surgical tech must remain alert throughout the entire procedure. If being used, the skin graft is placed at this point of the procedure. Wound closure may be performed as primary closure. Numerous stitches may be required to successfully stretch the existing skin to add the length necessary for closure. Procedural consideration: if a skin graft cannot be taken to cover a small surface of the palm, the wound may be left open to heal by second intention. Non-adherent dressings such as petrolatum gauze is placed with fluffs and an elastic bandage to hold the dressings in place for several days. A splint may be placed depending on the surgeon's preference. Post-operative diagnosis is the Dupuytrens contracture. Post-operative care and destination: patient is transported to the PACU. Elevate the arm on a pillow. Patient will be discharged the same day as surgery. Wound classification is a class 1 clean. Long-term prognosis: no complications. Some pain and swelling will occur. OTC analgesics. Ice applied. Arm should be kept elevated when walking and by the use of a pillow in bed. Physical therapy can be short-term or last several months depending on the extent of the repair. Possible complications, postoperative SSI, wound disruption. Minor wound disruptions are not uncommon, forcing the patient to wear a dressing for an extended period of time. Reoccurrence of palmar fasciotomy. Questions. Usually affects which 2 digits? And obviously I'm going to go ahead and answer for you guys, which is the 4th and the 5th. For extensive contractures, which incision is most commonly used? And that was the Z-plasty. Most valuable information was I didn't even know what a Dupuytrens contracture is, and I kind of didn't even know how to say it. I don't even know if I'm saying it right now. And then the hand anatomy. I mean, I knew some of it, but kind of get more into it here. And my references, and the end. Thank you guys. Oh, look. Little baby.